Greetings to all ophthalmologists and fellow residents at the 48th Annual Scientific Meeting of Paramita. My name is Carennia, and I would like to present my e-poster entitled The Dilemmas of Delayed Onset Toxic Anterior Segment Syndrome Mimicking Post-Operative Endophthalmitis. Toxic Anterior Segment Syndrome, or TAS for short, is an acute sterile inflammation due to surgical complication characterized by a non-infectious anterior chamber inflammatory reaction. This report emphasized that distinguishing TAS and post-operative endophthalmitis is actually challenging and also important due to the seriousness of the conditions and the divergent treatment strategies. The case was about a 66-year-old woman who came with blurry vision of the left eye since 1 week ago. She had a previous complicated cataract surgery, which was posterior capsular rupture, and her chief complaint was accompanied with red eye, painful sensation, and elevated IOP. Her left visual acuity was 1/60. And here, in Figure 1A to Figure 1C, we could see limbal-to-limbal corneal edema with Salzfuss 3 and 2 nylon sutures at the peripheral area that were actually in a good condition. We also performed the ultrasonography for her left eye and found haziness of the anterior until middle features. Hence, the patient was diagnosed with acute endophthalmitis, post-cataract surgery, and secondary glaucoma. Then we performed the vancomycin ceftazidime intravitreal injection for her left eye. After antibiotics injection, her visual acuity was still 1/60 and the inflammation was reduced, so we postponed to do the vitrectomy. However, 1 week after intravitreal injection, her visual acuity worsened to hand movement and her IOP raised again to 43 mm mercury. The results of her vitreous test was also negative. Patient was finally assessed with TAS and scheduled to undergo anterior vitrectomy. Intraoperatively, as seen here in Figure 2, we found fibrin clogging the anterior chamber. And 1 day post-anterior vitrectomy, her visual acuity was improved to 6/30 with IOP returned to normal, which was 11 mm mercury. So TAS in our patient was classified as delayed onset because TAS typically starts earlier than infectious endophthalmitis, which usually occurs 4 until 7 days after surgery. Patient with either infectious endophthalmitis or TAS may complain the same symptoms, such as painful sensation, they can have a severe inflammation, and it can cause a raised IOP, which happens secondary due to trabecular meshwork damage. From this case, we learned that severe inflammation, accompanied by vitreous haziness, may lead us to the diagnosis of endophthalmitis. In our patient, TAS is a diagnosis of exclusion from endophthalmitis in the absence of positive cultures and stains. Usually, TAS will resolve dramatically after the administration of steroids. However, in cases of refractory or unresponsive TAS to medications, surgical interventions such as anterior chamber washout or vitrectomy could also be performed. To conclude, mainstay treatment for TAS is steroids, but we should also consider surgical interventions if the patient is unresponsive to medications. So please keep in mind that endophthalmitis can cause potential detrimental and irreversible ophthalmic sequelae. Therefore, cases of unusual post-operative inflammation after cataract surgery are regarded as infectious endophthalmitis until proven otherwise. So that's all from me. Thank you so much for your attention.